Hello, friends. Welcome to Creative Medicine. In this lecture, we will learn about
intoxication by acetylcholinesterase agents, that is nothing but organophosphorus poisoning. Organophosphorus poisoning is seen in irreversible. Here it occurs mainly because of irreversible acetylcholinesterase inhibitors, mostly by organophosphates. Here these organophosphorus are present in agricultural insecticides, and these are frequently used for suicidal purposes, and also they are used for homicidal purposes. The nerve gases seen in organophosphorus poisoning are sarin, soman, and tabun are the nerve gases which can cause organophosphorus poisoning. This sarin, soban, and soman are used in warfare and chemical terrorism. Toxicity of these agents is mainly manifested by the nicotinic and muscarinic symptoms. So, treatment of this organophosphorus poisoning is general measures should be taken like airway, breathing, and circulation. The drug of choice for organophosphorus poisoning is atropine. This atropine should be given until the muscarinic symptoms will disappear, or until the signs of atropine toxicity appears. Atropine is virtually without effect on nicotinic receptors. It does not act on nicotinic receptors. So this nicotinic receptors can be reversed by pralidoxim. Pralidoxim is an acetylcholinesterase reactivator. It is beneficial in therapy of organophosphorus poisoning mainly. But this use of pralidoxim is always supplemented along with atropine. So for organophosphorus poisoning, you should use atropine along with pralidoxim. The other acetylcholinesterase which can be given are obidoxim. So we can also give obidoxim. Obidoxim is actually more potent than atropine. Then we can use diacetyl monoxamine. So these both are actually lipophilic, and because they are lipophilic, they can cross the blood-brain barrier. Then we have one more oxime, which is Hi6 oxime. It is more effective against the chemical warfare agents like nerve gases, like sarin, toban, and soman. For them, Hi6 oxime is more effective. So the drug of choice for organophosphorus poisoning is atropine, but you can also give, yeah, along with atropine, you will also have to give acetylcholinesterase deactivators like pralidoxim or obidoxim or diacetyl monoxamine. Especially if the organophosphorus poisoning is associated with muscle paralysis, then we should definitely give this pralidoxim, obidoxim, and diacetyl monoxamine. Atropine should be continued till the cholinergic symptoms subside. So here actually the pupil size is used as a marker for this, and this pupil size is used as a marker. One more marker for atropinization is tachycardia. Tachycardia is the most reliable sign of atropinization. And what is the most common sign of atropinization? Most common sign of atropinization is dryness of mouth. Then these oximes are not effective in carbamate poisoning. If there is carbamate poisoning, then these oximes are actually contraindicated in the carbamate poisoning, because in carbamate poisoning both the esteric site and the anionic site, both these are involved in the carbamate poisoning. But oximes will attach to the anionic site, whereas esteric site is attached by the organophosphorus, and as a result they can remove the organophosphorus. But in carbamate poisoning, the carbamate will attach to both the anionic site and esteric site, so that the anionic site is not free for the attachment of pralidoxim or oximes. So carbamate poisoning is oximes are contraindicated in carbamate poisoning.
thank you and thank you for watching.